The first program is on SABR in urological malignancies, being moderated by Dr. Indranil Mallick. Indranil, can I ask you to take the stage and also call up your colleagues and introduce them appropriately, because I would not know them completely. Okay, thank you. A word of warning, since we have broken ice by changing the nature of IST and starting on time, we will request you that we are going to be very harsh with the timings. The screen will go off at 9:30, and I would not, you're all friends, seniors and juniors, please don't take any exception if we are rude enough to actually stop the screen complete. Screen and microphone will go off at 9:30. Thank you.
Thank you, ladies and gentlemen. I would like to call upon the stage the panelists of this discussion. My name is Indranil Mallick. I am a radiation oncologist, a clinical oncologist at Tata Medical Center in Kolkata. May I call upon stage Dr. Shayan Paul from Apollo Super Speciality Hospitals, Dr. Srinanjan Basu, who's come all the way from Mumbai, Dr. Suman Mallick, also from Kolkata, from the Narayana Super Speciality Hospitals, Dr. Moses Arun Singh, my colleague at Tata Medical Center, and Dr. S.D. Shyam Sundar. And Dr. Shyam Sundar is from Kidwai in Bangalore. So firstly, I think that this is something new, isn't it? A urological society starting with a panel discussion on SABR in urological cancers. So yes, people are taking notice, isn't it? So I'm going to discuss two small cases. Can we have the screen, please? While we sort out the technical issues of the presentation, in the interest of time, I mean, just a question for all of you. This is also a kind of a peculiar panel discussion because there are only radiation oncologists in the panel. So how frequently in your clinical practice in urological cancers do you use SABR? Is it something that you use, all the time with the emerging evidence, or is it something that is used only infrequently? Dr. Suman Mallick can answer that question. Yeah.
Yeah. So if we compare a few years back compared to now, and day by day the indications of SABR is increasing. So even we are being more comfortable of doing SABR because now we have seen long-term follow-up of our own patients. So now we are more comfortable of doing SABR in especially early stage prostate, in some renal cell carcinoma, in some other metastatic lesions. So in lot of primary indications and even for metastatic sites, we are doing more and more SABR, so because
it's a part of your practice now. It's not something unique. So just for for some of the audience who are not radiation oncologists, which is probably most of the audience, a little bit of technological breakdown or nomenclature breakdown, which I confess that we confuse you with. So there are these terms that we use. We use SABR, which is stereotactic ablative body radiotherapy. This is a term that is very the most common term used in the UK, for example. In the US and in India, the term that we use is basically stereotactic body radiation therapy. When we give it in one treatment, and SABR and stereotactic body radiotherapy is a few fractions, few treatments of high dose radiation. When we give it in one fraction, we love to call it stereotactic radiosurgery. And there's this element of what is ultra hypofractionated radiotherapy, which is conceptually the same thing, but it doesn't take into account the additional information of image guidance and very, very conformal planning. But they're often used interchangeably. So let's start with the first case. We're already 5 minutes behind time, so let's be quick. So this is a 72-year-old man, hypertensive, on an annual blood checkup, was found to have a PSA of 12.1 nanogram per ml. He was asked to get an MP-MRI by the urologist, and you can see a representative T2 image. You can see that there is a hypodense lesion in the peripheral zone on the left. I'll just cut the long story short. There wasn't a clear extracapsular extension, although there is a long surface of contact. Biopsies were performed. Out of the 12 cores, 3 were positive. It was a Gleason 4+3, and 25% of the tissue was involved. As is often the case, although this is a bit controversial whether this needs a PSMA PET, but PSMA PET was done, and there were no nodal or distant metastases. Now, the question that I have to Dr. Shamsundar is how would you treat this patient? What would be your preferred treatment?
So the patient will fall into the intermediate risk category, probably because of 4+3 and a PSA of 12, not favorable, erring on that side. As there are no nodes or anything, I will be my preference will be to go with SABR. The dose being 35 to 40 gray in 5 fractions.
So what was the common dose that you would use? So you said you would use SABR, but what dose fractionation would you use?
Initially I was using about 40 gray in 5 fractions for smaller lesions, T1 especially. But after the recent evidence, I think
36.25? Okay. So I'll circle back to this question a little bit later. I'm going to ask Dr. Moses, do you think there's enough level 1 evidence that SABR is as effective as moderate hypofractionation?
Yeah, so definitely there is at least 2 randomized trials which have published their 5-year outcomes, and there is definite evidence to back it up as a standard of care for low and intermediate risk prostate cancers. So we have the results of the hypo-RTPC and also the PACE-B trial. Both have reported their
yes, so you very rightly you are pointing out to 2 large randomized control trials, 1200 patients, 850 patients. The hypo-RTPC, not perhaps a SABR trial, but still an ultra-hypofractionation trial, testing the same principles. The results, are you encouraged by the results? Do you think that they match what you would expect?
Yeah, I think they are fairly good results, and both were designed as non-inferiority studies, I think, and the biochemical recurrence-free survival at 5 years are pretty encouraging compared to...
Yeah, they're very closely matching, although they use slightly different dose fractionations. And if you probably calculate the alpha beta ratios, they're a bit higher on the SABR side, so we don't know, but the results are very, very encouraging. And the recent PACE-B results, Shayan, 95% control.
Yes. So these are very encouraging data, and like the large number of patients were examined, and as you all know that the radiobiology of prostate also says that if you hypofractionate and give high dose per fraction, it should be beneficial, and the normal tissue sparing will also be better if we use large
dose. So this case is an unfavorable intermediate risk cancer. Would you think that based on this evidence you would treat every patient with SABR preferentially? Is that something that you would consider?
Yeah, see, this is actually, the SABR is non-inferior to the moderate hypofractionated radiations. So I feel these cases are like ideal cases for SABR. Yeah. So we can save time, and we can deliver the treatment only in 5 treatments.
These trials, took slightly different patients. The PACE-B, a more favorable intermediate risk group, the hypo-RTPC, a slightly higher risk group, but their results are more or less matching. Yeah. So what about toxicities? That's what we are a conservative oncologist group of oncologists, aren't we? We know that radiation can cause harm, or in untested ways. Dr. Basu, what do you think about the toxicities that SABR has in this context?
So from the same group, they published the toxicity data as well. So for the grade 2 GI or GU, the acute, maybe at SABR, initially the GU acute is bit more, but at 5 years it equalizes. And most important is we hardly have grade 3 toxicities. What mostly been feared that we are giving a higher dose on a shorter interval, so probably end up to more late toxicity as traditionally we think, but that was not the case. Neither we see in our day-to-day practice. And most important, even the hypo-RTPC, though as you rightly said, it's not a classical SABR, it's maybe best called as ultra-hypo. They used a 3D CRT, most of the patients. So with a 3D CRT, a simpler technique, with none of us, most of us are practicing prostate SBRT would use it. So with that also the toxicities are so low. So then with image guidance, I don't think what traditionally prostate side effects when 10 years back as students we were taught of rectal bleeding and all, we hardly see in today's time.
Right, and are you concerned, Dr. Suman Mallick, are you concerned numerically slightly higher toxicities in the SABR trial but not still very low? Does that bother you, or do you think that we are in a safe place? Yeah.
No, actually, if you look at grade 3, grade 4, it's pretty low, only about grade 2 toxicities, and that is also around 5%, so near about 5%. So that is quite low. So we are more comfortable, but that also depends on how you are selecting your patients for SABR. So there are few cases where you may think of getting more toxicities, but those are also manageable. So it's not undoable, but it's
So you wouldn't get too worried about it. Can I simply put it that way, or is there still some concern? Do you think should I do SABRs or should I not?
No, usually initially we were quite conservative in doing SABR, especially post URP cases or bulky prostate. But now we see kind of similar kind of outcome with a moderate hypofractionation even with SABR. Because we also see higher toxicity even with moderate hypofraction in those group of patients.
So back to Dr. Shamsundar. I mean, we talked about choosing patients. Like, are there patients where you feel that not really a candidate for SABR? Are there things that you know that you're going to look for?
Probably node positive and very high risk patients. And relative indications are, what they used to tell, high volume disease. Right. Was one of the relative contraindications.
Yeah, we are going to come to that point. What about, Dr. Moses, what about TERP, prior TERP? Is that something that bothers you?
Yeah, so in the initial stages when SABR was being tested out, I think that those were considered to be relative contraindications, where we would choose patients not having had a previous urological procedure like TERP, or large size of prostate. All these were considered relative contraindications. But I do believe we have quite a few retrospective analysis of these settings. I think you're showing one of Dr. Vedang's paper as well, where they've done a matched analysis between patients who had undergone TERP and not undergone TERP in the same time period, and shown that the stricture rates were not that
different, not at least in the early follow-up. Yeah. And we know that TERP causes, I mean, person who needed TERP already has baseline problems. Yes. and likely to have baseline problem, maybe a bit more than the other group of patients without TERP, but there's no clear signal perhaps coming out in the literature yet. I think we probably need to treat more patients with TERP. And what about size? I'm going a bit quickly, we need to wrap up on time, as Dr. Ghosh said. Yeah. So does size prove to be a deterrent to you when you choose? If you have a patient who has a really big prostate, would you not give SABR?
Should I take that?
Shan? Yeah.
Yes. Till date, there are many studies going on large size. Like from India also, I think Dr. Vedang Murthy is doing one study. So the data is not still matured. So for very large sizes, maybe I'll restrict myself using SABR.
So that's still an unanswered question in your mind. Yeah, I mean, there's limited literature, and yeah, we have to be a bit conservative, but so far, nothing very, very serious coming out. What about high risk and node positive disease? Dr. Shamsundar mentioned that he is going to still wait. Do you think that we are ready to roll it out for high risk node positive disease?
I think we are pretty ready, and I know you are part of the protocol. Also, there's Indian study going on that. In my current practice, also for high risk, also we are doing SABR, but for high risk, we are definitely treating the node. For node positive, without any doubt, and we are incorporating hormone as we would have otherwise for high risk. So the technique not changing the overall.
Yeah, we don't have level 1 evidence. We have pooled multi-institutional data. This is the SHARP consortium data, and these results are pretty okay. And these are reasonable follow-up. I think they're coming up with an update soon. Yeah.
And the toxicity data also, I think you have.
Toxicity data is also there. Yeah, yeah. So the incidence of grade 3 toxicities are low in this data at least. So Dr. Moses, you're participating in the PRIME trial. Tell us very briefly about the PRIME trial. Yeah.
Yeah. So the PRIME trial is phase 3 randomized trial, of which at present 3 centers are participating. We are part of it, and Dr. Vedang is leading it from TMH, and Apollo Proton is also part of it. It's a trial which is looking at high risk and node positive prostate cancers, where we are doing 36.25 as the target dose, and with elective pelvic nodal irradiation as well, which is being compared with two different moderate hypofractionation.
Yeah. So this is the trial going on in India, about 470 patients, non-inferiority design, and we also have the PACE trials in the UK, the PACE-C, which is the high risk and unfavorable intermediate risk, which I believe Dr. Hughes can tell us whether, I think it has completed accrual. Yeah, and the PACE nodes, which has started accruing a few months back. So these are the trials that are really going to inform practice, and I think that we will wait for the results. Coming back to the dose question, very quickly, I mean, how high would you go? Are you mostly giving 36.25, all of you? Anybody giving 40 gray, like, PACE-B basically treated 40 gray to the CTV? Is that common practice, or are we usually a little conservative and sticking to 36.25?
So 36.25 in 5.
36.25. I think in India not many centers are treating to 40. Yeah, so we have, data. This is the best data we've got in the high risk group, and there's also, data from MSKCC, which is showing slightly better perhaps outcomes with 40. 45 or more, we don't go there. We know from Dr. Timmerman's study that's unsafe. And I'm going to quickly go over this because we need to go to the next case. So there are publications from India. At Tata Medical Center, Dr. Moses and I, we did a phase 1-2 study a few years back on this, and the TMH group have published on their results. So about 300-400 patients have been published. Not 300-400, maybe I think 250 odd patients are in the literature at the moment with their outcomes from India. So I'm going to quickly move over to the second case. This is actually Dr. Moses' case. This is a 77-year-old lady, diabetic, hypertensive, had a right nephrectomy for RCC in 2018, a left renal lesion in 2020 in the anterior cortex of the upper pole, small lesion. He had 2 consecutive ablations in December 2020 and January 2021, and was on follow-up quite well until end of 2022, when he had a local recurrence in that area. And at that point, this lady came to Dr. Moses, and there was a 2.1 into 2 into 4 centimeter lesion in the left renal upper pole. And Dr. Moses treated her with SABR. Now, I'm sure we're going to hear a lot about SABR and its applications in RCCs. Just a quick rewind. What are the traditional primary options in first-line management? We've got these two options. We've got partial nephrectomy, and it needs a medical fitness for GA. Long-term functional loss, there's a high variety in literature. Local control outcomes are very good. And we've got the traditional ablative modalities. Now, where does SABR fit into this? So, question to Dr. Paul. How strong do you think is the evidence for SABR at the moment?
This is probably will be the game changer in RCC because we are having very strong evidences for SABR. So this year Astro also, I think that fast track trial has been presented, and this is in the news all over the world. So it's a very good data of 70 patients data who are medically inoperable RCCs, and these are actually big tumors, not very small tumors like what RFA and other treatments would have been used. And this 100% local control, 100% cure rate. Only one patient, I think, record that is also outside distant metastasis.
I think that with SABR in RCCs, we've been a bit smart. Firstly, I think, as you know, the IROC registry is a multi-center registry. The data for partial nephrectomy and for ablation techniques have, for a long time, been criticized for being single-center, small groups of patients. Can't compare between each other. But this consortium has pooled in data, and they've come up with a number of publications. And I'm going to just ask your comments. This is a summary of the publications that have been there, and both the combined long-term results, 5-year outcomes. Not many ablation studies report 5-year outcomes. So what are your comments, Dr. Basu?
So yes, this actually were never considered to be a modality. I get that's what the IROC registry capitalizes. As you rightly said, they started with a single center. Shankar Shiva is the person of maximum work in this from Australia, but now since many other institutes are involved, and these people otherwise would have deemed nothing can be done for a very early stage disease for that matter. But this is a side, as Sayan also rightly said, that more and more data will come up in next 5 years, and this turned out to be, if we see the local control, it's excellent. It's actually 100%.
Yeah, that's the fast track too. I'm coming to that. So, Dr. Mallick, this is, they've published T1B, not a lot of reports of other ablative modalities in T1B. And the T1B results, these are all more than 4 centimeter tumors, mostly, 75% of them medically inoperable. They're really the poorest group. They published solitary kidney, which is also an unanswered question. What options do you have? And these results are, are you impressed? Do you think that these are better than what you would expect?
Yeah, so basically, when if you look at the data, these are poorly selected patients, which means, so those patients were excluded from RFA, micro-F, and renal function was poor, not suitable for partial nephrectomy, and in these cohort they have shown more than 95% survival. So that is quite eye-opener for all of the radiation oncologist or uro-oncology community, because so SABR going to be there for early renal CA, even for a large tumor. So it's going to be there.
And this is, these cohorts are different, as you mentioned. The median age is above 70. The tumor size is, the usual median tumor size in these is 4 or more. So, and they're, the renal morphometry scores, I haven't put all the details in this table, but they're the worst kinds of patients. And these results are very encouraging. And circling back to the single kidney outcomes, and that's the unique problem, isn't it? I mean, these are notoriously difficult to treat. And, you know, the results show that the outcomes are very similar, whether it's single kidney or dual kidney, and they are all more than 90%. Now, you mentioned Fast Track 2. I think Shayan mentioned Fast Track 2. So Fast Track 2 is a prospective phase 2 trial. And this was reported at the Astro meeting a few months back. And they took a pragmatic approach. So single fraction stereotactic radiosurgery for less than 4 centimeters, a fractionated approach for more than 4 centimeters. And I've just, you know, taken the slide from their presentation. And that's remarkable, isn't it? I mean, I'm pretty sure this is better than what they expected. So I mean, this is something that is great. So, you know, is radiotherapy a problem for lesions that are bigger than 3 centimeters or close to the hilum? Not from this data, isn't it? Not from this data. What about close to the hilum? That's a problem for ablation. And you know, Dr. Paul, is there any you know, indication that it's dangerous close to the hilum?
I don't think we have enough data to say that we have.
I think that whatever reports there have been, they have included patients who are close to the hilum. And because it's not, you know, an immediate destruction, the pattern of cell killing, the modality of cell killing makes it safer. Sure. But, you know, when we are talking about, you know, RFA or cryo, there is a bit of a problem in terms of size.
Yes. SABR in this term is much safer than RFA and cryo and other invasive procedures.
Yeah, so these are, I think, you know, some of the references from the EAU guidelines that they point out that the reported outcomes in the larger tumors, more than 3 centimeters in size, have really been subpar, and it's well recognized. So ablation is a fantastic modality for small tumors, but it's not that great for slightly larger tumors, where, you know, the SBRT outcomes are really brilliant. And that's and if you look at these curves, the local failure rate of less than or more than 4 centimeters is more or less the same. So that's something that but what about the renal function? You know, is renal function, you know, traditionally we try to be very conservative with doses to the kidneys when we're treating abdominal tumors. You're going to treat very high doses to a part of the kidney. What do you think is the issue, Dr. Moses?
Yeah, I think with every modality there is going to be a drop in renal function, and with SABR, even in solitary kidneys, we have seen that it is still safe, and not many patients ended up getting dialysis, and the patients.
So the dialysis rate was how much?
I think about 4% or something.
3%, 4%, yeah.
And even those were, some of them were already dialysis.
And what was the, you know, if I remember correctly, the cutoff, I think people were taken up for SABR with a GFR of 30.
Yeah.
30, 35. Yeah, so these are patients who are already very, very compromised. So it's notoriously difficult to compare GFR loss, because there are all, you know, hardly studies which have direct comparisons. I did find this meta-analysis from Yanagisawa, published in Urology Oncology, where studies have directly reported outcomes. And my first impression was that I thought partial nephrectomy was much worse, but that's not the case. I mean, at least from my reading, I think that it's, well, I mean, there are some studies which show that it's, you know, there's loss, but it's actually a lot better than I expected from this particular publication. And more or less everybody is the same. Although it has to be said that the baseline function is really different. You know, in the partial nephrectomy, they're usually the best baseline function. Their GFRs are in 80s, 100s, 120s. The RFAs are somewhere in the 70s, 80s, most of the baseline reports that I have read. Whereas the poor radiotherapy cousins are treating people where the average is 60. So Dr. Shamsundar, if you've got a bad denominator, you are disadvantaged. But yeah, so do you think we've done okay?
We have done really well, I think better than what we have expected. And also, this will be a real boon to patients with single kidneys, where the sparing of the renal function will be of utmost importance. I think this data will really, support the use of SABR in especially these patients.
Right. So what about the preferred dose fractionation? Oh, we are out of time. We'll take 2 minutes. Yeah.
So the fast track dose fractionation probably will be using.
So you want to use the fast track dose,
Yes.
which is a single fraction?
Single fraction for less than 4 centimeter and fractionate if it is more than 4 centimeter, because this is the strongest data we have.
Yeah. Yeah, I think I agree with you. From the long-term outcomes, it was very clear that whether 4 centimeters or more or less, the single fraction outcomes are the best, probably because of the other cell-killing modalities of ablative, really ablative, high ablative doses. But the 42 gray in 3 fractions did very well too, because it's 100% in any group.
Yes.
Now, a slightly tricky question: how do you follow up patients with post-SABR?
So
I think this would be probably the last question.
So one thing after the kidney SABR, there may be a slight increase in the initial 3 to 6 months in the size. That's a sort of like in brain we get a pseudo progression, and over a period of time it then settles. It is proven in whatever available data as of now. So that should not be alarming, and this is true for more or less any site SABR except for metastatic sites. Any primary sites we treat, their initial scans probably show a certain increase in just the size component, but one has to wait for longer months to see the actual response.
Yeah, and the other point is about the biopsy. I think that's, I think thrown people off, and it's very clear that you don't do biopsies after radiotherapy in any setting. In head and neck, whether it's head and neck cancer radiotherapy or whatever, you'd see the control outcomes. You don't do biopsies because the cell death from radiation is different. There will be viable looking cells, not necessarily leading to outcomes. Thank you. Just last point. Do you think it's ready for guidelines? Do you think we're there?
Absolutely.
I think it should come.
Yeah.
Right. Let me ask, because it's a surgical society, it's a very good conversation. Professor Alnostanzel, what do you think? Is partial nephrectomy going to die, or is SABR going to create a new space? Very briefly, can you give the surgeon's view?
Well, first of all, I think, we have shown here the results of experts. Great. Well, how does it look like when you go to the real world experience? Not so nice people doing it, as you know, they have not been taught. That's one thing. The other thing is, ready for guidelines? I think there are more strict ways to put these things into guidelines. You have to have a better head-to-head comparison. That is, we all know how guidelines nowadays work and how really thoroughly they have to look at so that really the entire community can do it with the same results. We have so much experience now with other ways of treatment. And so, you've seen partial nephrectomy versus nephrectomy. It's difficult. There are some cases where it's no difference at all.
So would you be open for a randomized control trial of SABR versus partial nephrectomy?
I do think that is, because both are treatment options. And
that's what the fast track slides ended with, that, we now demand that there be a randomized control trial because we are very confident of our outcomes.
And that will never happen.
Khurshid, you're the guidelines man. What's your opinion on this? A very brief opinion on this.
For the prostate or for the kidney? For the kidney.
Both.
Well, for the prostate...
Prostate, I'll come to Procor, but can you comment on the kidney?
Sure. Well, you should be answering both. But I think for this, yes, trials, but the question I have is, there's a big support for active surveillance. In kidney,
Yes,
and you
yes.
separate those
Yeah.
tumors. You kind of have mixed the bag here a little bit. So we have to separate those patients. That's one. Second thing, which is true for both prostate and kidney, and I'm going to take a little bit from steam off Procarb, that it's all about survival. It's about their life expectancy. And what is the real story with the patient? I
Yeah.
think these are two simple points.
Yeah, I think I take your point. I should have mentioned active surveillance. I think it's a very good option for many patients. Yeah.
Prokhor, your closing remarks on this, please.
Closing remarks are a fallen mind. Look, in the prostate cancer patient, 4+3 fit man certainly should be treated. Unless he was unfit, there is no reason.
No, I think he was mentioning. Was he mentioning active surveillance for the prostate? He was talking about the kidney.
Yeah,
Yeah.
but I think
Yeah.
Prokhor is pointing towards a very good point.
Yeah.
4+3
Yeah. Yeah.
4+3. So, in this case, however you treat it, whether it be with SABR or with surgery, the patient will do well. The mistake we make as doctors is ignore the mind of the patient. If the patient is otherwise fit and they can't live with it inside their body, there is only one way to treat it, to take it out. On the other hand, we have to be equally honest with the patient and no longer say that surgery is better than radiation. I think that is dead, and the only randomized trial which exists, it gives us good data, shows that
Yeah.
it is dead.
That's
so
correct.
we have to deal with the mind of the patient
Yeah.
in addition to their fitness.
Thank you very much. I think it was a lively discussion. However much Indranil you might have felt out of place, time has come for India to wake up and make a real good case out of multidisciplinary therapy.
Yeah. Thank you to all the panelists. Thank you.
Can we ask